Good day, everyone. I'm going to be talking to you about echocardiography in heart failure, LVAD, and transplantation. So why do we offer people an LVAD? Well, the wait times for cardiac transplantation are very long. Large numbers of patients exist with end-stage heart failure. The one-year survival on LVAD support is improving, and in those awaiting transplant, it is between 55 and 85%. More than 30,000 LVADs are implanted worldwide. Here you can see the different types of LVADs, the HeartMate 2, the HeartMate 3, and the hardware LVADs. These are the most common LVADs in North America. What are the clinical indications of these LVADs? Well, one is bridge to transplantation. The duration of support here in this case can be anywhere between 6 to 12 months. These maximize survival until transplant. Number two is for destination therapy. The duration of support here is indefinite, and the purpose is to maximize functional capacity and quality of life. One-year survival in these patients is approaching 80%. Number three is for myocardial recovery, which is something that we all hope for, and potential explantation of the LVAD. And the purpose of the LVAD here is to maximize LV reverse remodeling. So just to remind you of the LVAD circuit, remember that this is a HeartMate 2 LVAD, and the LVAD removes blood from the LV apex, as you can see here, and returns blood via the graft to the ascending aorta. There are three main internal components to the LVAD. There's the inflow cannula at the LV apex, the mechanical impeller, the outflow graft, which is connected to the ascending aorta. Now, LVADs are not available at every institution. I find this demonstration here helpful for your understanding of how an LVAD works. This is a HeartMate 2 LVAD. You can see that it is subdiaphragmatic with the inflow cannula here, the axial pump here, and the outflow graft anastomosing to the ascending aorta here. This is the hardware LVAD, also called the HVAD. And you can see that this one is an intrathoracic LVAD with the outflow graft here and anastomosing to the ascending aorta here. So blood goes from the LV cavity in through the inflow cannula towards the outflow graft and into the ascending aorta. The purpose of the LVAD is to give the left ventricle a more normal shape. So this is actually a patient pre-LVAD placement. This is the endocardial surface of the left ventricle before LVAD placement. After LVAD placement, the LV is afterload reduced, and it looks more bullet-shaped, as you can see in this here. This is just a schematic to show you what happens pre and post LVAD placement. This is a diagram showing the right atrium, the right ventricle, left atrium, left ventricle. Here's the aorta, the main pulmonary artery, and here the SVC, IVC. So initially, before the LVAD goes in, the patient is in end-stage heart failure. There's a low cardiac output. There's increased LV and diastolic pressure, increased left atrial pressure, increased pulmonary capillary wedge pressure, increased right atrial pressure, increased CVP, and increased IVC pressure as well. When the LVAD is placed, as we said before, the inflow cannula goes into the left ventricle, and the outflow cannula, anastomosis with the ascending aorta. And the LVAD results in increase in cardiac output, and in so doing, decrease in pulmonary capillary wedge pressure, decrease in left atrial pressure, decrease in LV EDP. But one of the things that occurs with the LVAD when it's first placed is by increasing the cardiac output, it increases the preload to the right ventricle. And initially, you may see an increase in CVP, an increase in right atrial pressures as the right ventricle starts to accommodate to the LVAD. Whether or not the right ventricle can accommodate the LVAD depends very much on some factors intrinsic to the right ventricle and other factors. So when do we do echocardiography in these patients? Well, these are some of the clinical indications. One is for surveillance, to basically to catch any drift from baseline echocardiogram. Two is to determine the optimal device setting with or without speed changes. Three is to assess any complications such as thrombosis, inflow-outflow cannula obstruction. And four is to assess any LV recovery. So let's look at the echo in an LVAD patient. The very first screen should tell you the type of LVAD, whether it's a heart rate 2, an HVAD, or so forth. It should tell you the RPMs of the LVAD, and it should give you some preliminary parameters. For the LVAD evaluation, you want to know LV size, that is the LV end-diastolic and end-systolic dimensions. You want to know about aortic valve opening, aortic insufficiency, and we'll talk more about these things in the coming slides. You want to know about interventricular septal position. You want to know about right ventricle size and function, mitral regurgitation. You want to know about the inflow cannula, the outflow cannula, any thrombosis that might be present, and you want to know about the pericardial sac. These are some images from a patient who was having a surveillance echo. You get the LV size and function parameters from the parasternal long axis view. This person has a very enlarged left ventricular end-diastolic dimension. You obtain aortic valve opening also from a zoomed view of the aortic valve. This can be obtained from 2D, as you can see here. And in order to maximize your assessment of the aortic valve, it is a good idea to obtain at least 3 beats on 2D imaging of the aortic valve. And then also assess aortic valve opening on M mode. This is also very useful. It can be done both in the parasternal long axis view or in the long axis view of the aortic valve, and also in the short axis view of the aortic valve. Sometimes it's very useful when the patient has a bioprosthesis. It makes aortic valve opening easier to see. Aortic regurgitation is also assessed from the parasternal long axis view, and once again zoomed on the aortic valve with color. What is important here is that aortic regurgitation in LVAD patients can be continuous, and the measurements that we use conventionally for aortic regurgitation assessment are not necessarily reliable in these patients. You also need to assess mitral regurgitation. You need to assess the interventricular septal position, and that is done in the apical 4-chamber view. And then the inflow cannula and the outflow cannula assessment. And these are CW Doppler velocities through both, which are important. We'll talk about that. And then the pericardial sac. So let's talk a little bit about the interventricular septum and the left ventricular size. So here are 3 different patients. You can see that the interventricular septal position differs significantly between these 3 patients. This is a rightward shift in the interventricular septum. In this patient, there is inefficient left ventricular unloading. And here, you need to think about why that might be happening. Here is a midline interventricular septum. This is efficient LV compression. And here is a leftward shift in the interventricular septum, showing you that the left ventricle here is markedly unloaded. When you see a decrease in LV size with the interventricular septum shifted towards the left, as you saw on the far right-hand side of the previous slide, you need to think about things like hypovolemia. Is the patient dehydrated? Are they having diarrhea, vomiting? Are they not eating, drinking? These kinds of things can cause decrease in preload and can cause the interventricular septum to shift towards the left because the LVAD remains at the same speed. Normally, we would adjust our cardiac output, but the patient being totally dependent or mostly dependent on the LVAD, and this because the speed cannot be changed unless the patient actually sees their physician, there is a large impact on the left ventricle with all these hemodynamic changes. You should also suspect the presence of suction events. If you see a decreased left ventricular size, with the interventricular septum shifted towards the left, and also right heart failure. In these cases, the RV is usually dilated. If you see an increased LV size with the interventricular septum shifted towards the right, think about inflow cannula obstruction, outflow cannula obstruction. We'll give you examples of these. Think about significant aortic regurgitation, and think about the presence of thrombus. In these cases, inflow cannula obstruction, outflow cannula obstruction, and thrombus, you may see increased aortic valve opening because the left ventricle, the heart is no longer depending on the LVAD because something is obstructing or reducing the ability of the LVAD to work, and that is when the native heart takes over, if there is any native heart function, and you will see increased aortic valve opening in these cases. So let's talk a little bit about thrombosis. Now, thrombosis in patients with LVADs can happen anywhere. Here's an example of an aortic root thrombus. You can see it on the parasternal long axis. Right? This is a close-up of it. You can see it on the short axis as well. There's the thrombus. And then you can also see it with contrast echocardiography. This is a 50-year-old man who was 1 month status post HeartMate 2 LVAD. He was ready to go home after a lengthy admission, and this echo was actually done prior to discharge. Now, what this echo actually shows us is it is very important to, even if the echo looks like it's of poor quality, to take all your images, because you never know what you're going to find. And that is exactly what the sonographer did here. You can see the parasternal long axis view. As expected in these patients who have recent post-op LVADs, the image quality can be poor. However, we can tell that the left ventricle, we could measure the left ventricular dimension if we had to here. We can see the mitral valve as well. In the apical 4-chamber view, you can see that the interventricular septum looks midline. But in the apical 5-chamber view, you notice this echo lucent, very mobile density here in the LV outflow tract. So this patient went on to have a TEE, and you can see that echo density under the anterior leaflet here. It is bright at the edges and lucent in the center, very suggestive of fresh thrombus. You can see it also here, and you can see it here, where it actually closes over the LV outflow tract. And you can see it underneath the anterior leaflet of the mitral valve, covering the LV outflow tract in the 3D image. This is actually looking at the mitral valve from the left ventricular perspective. Let's talk a little bit about aortic valve opening. So this is aortic valve opening on 2D echocardiography. As I mentioned before, it is a good idea to zoom into the aortic valve and to watch the aortic valve over at least 10 or so cardiac cycles. This is an example of a closed aortic valve. This is an example of an aortic valve that is intermittently opening. This is an example of an aortic valve that is opening normally. You can see the same thing with M-mode echocardiography. This is a closed aortic valve. You can see how clearly that it shows up. You can see here an intermittently opening aortic valve with reduced excursion. You can see here an aortic valve opening every week. So what is the impact of aortic valve opening? If you look at this graph here, if you have a closed aortic valve, then there is a greater likelihood of developing aortic regurgitation in the months following LVAD placement. So your freedom from aortic regurgitation is less if your aortic valve is closed. However, if you have an open or intermittently opening aortic valve, you have more freedom from aortic regurgitation. Remember that aortic regurgitation in an LVAD patient does not have a good prognosis. It changes the hemodynamics, and it actually decreases the prognosis for the patient, and we'll show a little bit more about that in the coming slides. For aortic insufficiency, as I mentioned before, you can see here the aortic insufficiency is often continuous. So it occurs during both systole and diastole, continuous, and not only during diastole. And this is a very good example here. The overall volume load that the ventricle actually sees is greater because of continuous aortic regurgitation. And it is often eccentric and poorly measured by the traditional echocardiographic measures such as vena contracta and PISA. These tend to underestimate the severity of aortic regurgitation, especially because it's continuous. So in terms of the time course of aortic insufficiency, here on the y-axis, you can see freedom from increased aortic insufficiency, and then over time. So over time, this is 237 patients with a HeartMate 2 LVAD, and you can see that over time, freedom from aortic regurgitation decreases. So the tendency is for aortic regurgitation to happen over time. And this is actually over years. So patients with LVADs tend to develop aortic regurgitation given enough time. So in terms of the histopathological changes leading to aortic regurgitation, and remember these changes are more common in those people with closed aortic valves. They get increased local fibrosis, thrombus formation. They get aortic root remodeling and dilation. They get aortic valve degeneration and remodeling. They get commissural fusion, and they get leaflet malcoaptation. And this is an example of a patient here with an LVAD. You can see how distorted the aortic valve appears, and this is actually a closed aortic valve. And over time, you can imagine that the aortic valve gets destroyed, commissural fusion, degeneration, remodeling, and so forth. So let's talk now a little bit about the inflow cannula. So these are some of the problems that can happen with inflow cannulas. You can have malposition, you can have occlusion, you can have thrombosis. It is very important to interrogate the inflow cannula. This is actually an example on transesophageal echocardiography. The inflow cannula is usually positioned at the LV apex and oriented with the cannula pointing towards the mitral valve. This is the normal orientation of the inflow cannula. And when it's orientated like this is the perfect alignment with the CW Doppler, beam, and you can obtain a jet or a CW Doppler profile and measure the maximum velocity through that inflow or through the inflow cannula. Now, one of the things about transesophageal echo, when the inflow cannula is positioned just right, the midesophageal four-chamber view is a good place to obtain the CW Doppler tracing through the inflow cannula. However, in the parasternal long axis view, sometimes it can be difficult, or in the transthoracic echocardiography, it can sometimes be difficult to obtain the inflow cannula in the correct position so that a good CW Doppler tracing can be obtained. Sometimes it requires maneuvering from the short axis perspective to get that cannula in good alignment with the CW Doppler beam. So the abnormal inflow cannula. Mechanisms of inflow cannula obstruction include thrombus formation, inlet occlusion by trabeculations, cannula angulation into the myocardium, and I'll show you that, and then malposition due to underfilling of the LV cavity, and I'll show you that as well. So here's an example of a cannula that is not positioned so that it's pointing towards the mitral valve. In fact, it is not positioned at the apex. It is actually pointing towards the septum. So this is not really where you want the inflow cannula to be pointing. This is another example of an inflow cannula that is pointing towards the wall of the ventricle here, not towards the mitral valve. So this is a 74-year-old female with an LVAD who complains of shortness of breath, fatigue, and exercise intolerance. So she comes into the emergency room and an echo is performed. You can see that her inflow cannula is actually pointing towards the septum. You can see that her LV cavity is small, 34 millimeters. So this patient is underfilled. The LV cavity is underfilled. You can see here, if you look very closely, that there is also a suction event with the cannula sucking on the myocardium, because remember, this cannula is active, right? The LVAD is on, it has a certain speed to it. And because there is shifting of the interventricular septum, and you can see it here towards the left, because of the suctioning, because of the underfilled LV cavity, what happens is that the right ventricle dilates. Right atrium also dilates because that septum is pulled towards the left ventricle. This is not a good thing because when the right ventricle dilates, the annulus gets bigger and you get significant tricuspid regurgitation, which long term and even over the short term is not a good thing. These are other examples, or in the same patient, of how you can get suction events. You can see very clearly the inflow cannula is sucking on the myocardium there. And when we obtain a velocity through that inflow cannula, we got 3.6 meters per second, which is high. The normal velocities for inflow cannulas are around 2, 2.5, 3.6 is high. So let's talk now about outflow cannulas. And some of the problems that can happen with outflow cannulas include kinks, obstruction, thrombosis. So first of all, the normal outflow cannula. So this is transthoracic echocardiography here. This is transesophageal echo. With transthoracic echocardiography, this is the right suprasternal, or it can also be the high parasternal. You can see the ascending aorta here. You can see the sinus of Valsalva down here. And you can see the anastomosis of the outflow graft right here. You can appreciate it here again with color. And this is where the blood actually flows into the ascending aorta. You can see very nicely here. And it's also very well aligned for the CW Doppler jet. And here we obtain the CW Doppler jet, and you can obtain a maximum velocity through the outflow cannula here. This is a transesophageal echocardiography. And you can see here that the outflow cannula has an anastomosis with the ascending aorta here. And this is also a perfect alignment for the CW Doppler velocity, and you can see the CW Doppler tracing obtained here. So typically, you can obtain these outflow cannula velocities in the right parasternal position. Sometimes the patient, it's easier to obtain when the patient is lying on their back. Sometimes a suprasternal needs to be used. So you need to practice this in order to be able to get this window in these patients. Now, the outflow cannula peak velocities actually depend on LVAD type. So this is just a variety of LVADs, and this is data from our echo lab showing that the HeartMate 2 peak velocities cluster around 1 to 3. The HVAD cluster around 1 to 3.5. The HeartMate 3 clustered around 1 to 2.5. So really, abnormal velocities tend to be 2.5 and above, or 3 in our experience. So here's an example of a 61-year-old man whose status post HeartMate 2 for ischemic cardiomyopathy. His peak outflow cannula velocity was 3.9 meters per second on 13-day follow-up echo, 13 days after LVAD was placed. So here you can see his outflow cannula. You can very nicely see the anastomosis of the graft with the ascending aorta here. And you can also appreciate that there is turbulent flow here. And the velocity was 3.9 meters per second. So we looked a little bit more into this because the velocities were so high. And you can see that there's probably a kink there, even on 2D echo. And with the CT, you can visualize this kink very clearly right there in the outflow cannula. So initially, this patient did well, and they didn't really want to do anything about this. But a couple of years down the road, as the LVAD and the graft got older, the patient started becoming more symptomatic, and this was actually replaced. Here's a 48-year-old woman, status post hardware LVAD for ischemic cardiomyopathy as bridge to transplant. She was admitted for shortness of breath and chest pain. You can see her right heart cath numbers here. Wedge is high. You can see PA pressures are high. And here you can see, again, the outflow cannula anastomosis to the ascending aorta. There is turbulent flow here. And in fact, the outflow cannula velocity was 3.4 meters per second, which is also high. And when you look at the sinus of Valsalva, you'll see this abnormal turbulence in the sinus. And this is also a clue that there is a outflow cannula obstruction. So this patient went to the cath lab, and they shot dye into the aorta, as you can see here. And if you watch very closely at this aortogram, you cannot see the outflow cannula. So the outflow cannula does not light up. The graft itself does not light up, does not take up the contrast, suggesting that it's completely occluded. So then they put a wire down into the outflow graft, as you can see here, and they actually ballooned it, and you can see it here showing up. And then they stented the outflow graft. And if you look very closely, you can actually see the stent there between the yellow arrows. And then when they did another aortogram, now you can see that the outflow graft is open. And post-stent, you can actually see the stent in the transthoracic echo. It looks a little scary. You can see the stent here, sticking to the ascending aorta here. And this is what the color looked like in the stent. Now let's move on to talk a little bit about LVAD speed optimization. So remember that in real life, when we lie down to go to sleep, when we walk, when we run, our cardiac output increases to accommodate what we want to do. But in these LVAD patients, they are totally dependent on the speed that they are set, the set speed, set RPMs of the LVAD. That does not change. They cannot change it at home, right? If they want to increase that activity, they depend on that speed. So it's very important to set that speed to give the patient the best quality of life that they can have. And this is where the RAMP study comes in. The RAMP study is it's a study that we do with echocardiography. And what we do is we increase the speed settings of the LVAD and by set increments, and obtain echo images at set increments as well, to optimize the function of the LVAD. And what do we mean by optimize the function of the LVAD? Well, in terms of echo, you want to make sure that the interventricular septum is midline, so that the LV is efficiently offloaded. You want to make sure that there is as little aortic regurgitation as possible. You want to make sure that the aortic valve is intermittently opening. You want to make sure that that there's as little mitral regurgitation as possible. And so these are the images that we actually take at specific intervals on the RAMP study. So this actually illustrates the intervals, the RPM intervals that we use for the HeartMate 2 LVAD and for the HVAD in blue. That is one of our sonographers taking images, in this case in the cath lab, because we also did some of these RAMP studies with hemodynamics at the same time. And and then once the RAMP study is over and they decide which speed they want to set the LVAD to, the LVAD speed is changed to that. The RAMP study is stopped if there are any suction events, and if the end diastolic diameter of the LV reaches less than 3 centimeters. Of course, before starting the RAMP study, we need to make sure that the INR is more than 1.8, PTT greater than 60, that there's no LV thrombus and no aortic root thrombus. And no thrombus anyway. So as I mentioned before, the purpose is to optimize device speed without compromising cardiac function. You want to make sure that the mean arterial blood pressure is greater than 65, that the interventricular septum is maintained in the midline position, that there's intermittent aortic valve opening, no more than mild mitral regurgitation. And you can also use the RAMP study to evaluate for LVAD malfunction. We have done that a couple of times. So in terms of the RAMP test protocol, here are the speeds that you could potentially use for the HeartMate 2 LVAD, for instance. You record at each speed setting the LVAD parameters, the patient parameters, and then the echo parameters. And these are the echo parameters that we talked about in the previous slide. So with increasing LVAD pump speed, as expected, the LV cavity should decrease. So you can see here, this is the same patient. All these images are taken of the same patient. And you can see that at 800 RPMs, the LV cavity measures at 74 millimeters. And then at 10,400 RPMs, the LV cavity measures at 63 millimeters. So it has decreased from here to here by about 10 millimeters, a little more than 10 millimeters. Now, as you go to the high speed, you expect that the interventricular septum is going to shift towards the LV. And remember, we mentioned before that when that happens, at the extremes of speed, as you can see here, initially the RV also compensates for that, and you don't see much of a change in the right ventricle. But eventually, when the speeds get very high and the septum is shifted leftward, the RV starts to show dilation. You may even get tricuspid regurgitation, and you know that you don't want to set the patient's speed at this level. So with increasing LVAD speed, the aortic valve closes. And that is because of the pressure differential across the aortic valve with increasing speeds. So you can see here at 800 RPMs, you can see the aortic valve is opening. If you watch carefully, you can also see the aortic valve opening here. And then at the highest speed here, the aortic valve is closed. So as we said before, we want to maintain intermittent aortic valve opening. And so you don't want to set the pump speed at this point. You don't want to leave the pump speed here at the lowest level. With increasing LVAD pump speed, aortic regurgitation increases. That is also because of the differential pressure across the aortic valve with increasing speeds. You can see here that you already have at least mild aortic regurgitation. That becomes perhaps moderate aortic regurgitation here because it's continuous. And then there's significant aortic regurgitation here at the higher speed. With increasing LVAD speed, mitral regurgitation gets better, right? Because the wedge pressure goes down, and as we said before, the mitral regurgitation therefore improves. And you can see here significant mitral regurgitation, which goes down here, and almost no mitral regurgitation here at the highest speed. So this, and I'll wait for a second so that it can all play on your recording. This is an example of a ramp study. Okay, so let me just take you through this. This is in a single patient. This is the 800, the lowest speed. Again, it's a heart rate 2, 800 and 8,800, 9,600, 10,400, 11,600. And you can see that the LV end diastolic dimension decreases with increasing speeds. And you can see that aortic regurgitation, as we talked about, increases with increasing speed. Mitral regurgitation decreases with increasing speed. And the aortic valve closure, the aortic valve remains closed for a longer period of time with increasing speeds. Now, one of the things that I did not mention before is that when we assess aortic valve closure, one way of assessing it is to assess it over 10 beats and to say that the aortic valve is open 3 out of 10 beats, for instance. So that'll be 30% of the time. And that's how we did it over here. You can see that the aortic valve opening here was 100% with every beat, and then slowly 30% and then closed. So you don't really want to set the speed here because the aortic valve is closed. And that's bad because the patient has a lot of aortic regurgitation here. You don't want to set the speed here because the LV is not sufficiently offloaded here. Finally, in these two settings, you are getting some effect of the LVAD. So the decision has to be made where here is it best to set the LVAD speed, and might even be in the middle of these two. Now, in this patient, we happen to have hemodynamic data available as well. And so that gave us added information. With increasing LVAD speed, you can see that the CVP decreases. You can see that the pulmonary artery pressure, mean pulmonary pressure decreases. The wedge pressure decreases, the PA-SAT decreases, the cardiac output increases. And so if you match that up with what's happening in echo, in the cath lab, we came to the conclusion to set the LVAD speed somewhere at 9,600, a little bit above that. So in order to assess the LVAD, first you have to assess the inflow cannula for malposition, occlusion, malfunction, thrombosis. We need to assess the mitral valve for any regurgitation, thrombosis. We need to assess aortic valve opening, regurgitation, thrombosis. We need to assess the outflow cannula for kink, obstruction, thrombosis. We need to assess the pericardium for any effusion, tamponade, hemorrhage, especially in the post-op setting. You need to assess the septum for malposition, for LV dimension, and you need to assess the right ventricle for failure, tricuspid regurgitation, thrombosis. So let's do one case, an LVAD malfunction case. This was a 50-year-old female with a history of idiopathic cardiomyopathy who had a HeartMate 2 placed about 6 months ago. She had a 2-day history of shortness of breath and fatigue. Her lab values were consistent with hemolysis. And you can see that her X-ray shows pulmonary edema. There's her HeartMate 2 LVAD, which is subdiaphragmatic, and she has an ICD as well. And so in order to assess what was going on here, a ramp study was performed. Now there's already a clue in the hemolysis. Remember that with normal LVAD function, the size of the left ventricle decreases with increasing speed. Aortic valve closes at higher speeds. There's increasing aortic regurgitation, decreasing mitral regurgitation, and the shift of the interventricular septum to the left. So what happened in our patient? So we increased the speeds all the way to 11,200 in this case, and the LV dimension did not change. The aortic valve opening also did not change. And this patient actually had a thrombus in the inlet stator. So you should consider LVAD thrombosis in those patients with worsening heart failure with signs of hemolysis such as a low haptoglobin, elevated LDH, with device malfunction. So these patients, and this patient also had it, do have alarms, flow alarms that occur on their LVAD that alert them to something going wrong with their LVAD. That's why they call the LVAD coordinator and sometimes are told to come into the hospital if it's not something that can be resolved over the phone. And then an echo ramp test can help, as in this case, demonstrate no change in LV end-dash dot dimension with increasing LVAD speeds. Let's now move on to talk about echocardiography post-heart transplantation. So heart transplantation is a life-saving option for patients with end-stage heart failure. The first human-to-human heart transplant was performed in 1967 in Cape Town, South Africa. It took 9 hours with a team of 30 people. Today, there are two main approaches to heart transplantation that you may see on echocardiography. The biatrial approach is the older approach, and it has now been replaced by the second approach, which is the bicaval approach. So let's talk about these two approaches to heart transplantation, as they will help you understand what you are looking at when you see a transplant patient on echocardiography. So in A, we show the biatrial transplant. In B, the bicaval or more common type of transplant operation. This information comes from the European Heart Journal Cardiovascular Imaging 2015 manuscript. So in the biatrial operation, there is an anastomosis made at the mid-level of the left and right atrium, and the aortic and PA anastomosis occur above the semilunar valves. The appendages are removed. The right atrial incision is close to the donor SA node. Necrosis of the SA node and sinoatrial node dysfunction can happen in this type of surgery. Atrial geometry is distorted, resulting in enlarged atria, and large parts of the recipient atria are retained in this type of operation. As I said before, the biatrial operation is largely replaced by the bicaval operation, which is shown in B. This is the most common, and here the donor heart is connected through bicaval anastomosis. The left atrial incision is carried to the base of the left atrial appendage, which is removed, leaving a small margin of the atrial cuff around the 4 pulmonary veins. There is better preservation of the anatomic configuration of the heart and a decreased need for permanent pacemaker and improved survival in these patients. Now, the very last operation that I show you here is in C, and that is called the complete atrioventricular cardiac transplantation. It has separate cable and pulmonary vein anastomosis, as you can see. But this has a lot of technical issues and is not used anymore. And here you can have bleeding from the suture lines of the pulmonary veins, reduced patency of the pulmonary veins due to twisting and stenosis and or at the anastomosis sites. And with this increased complication rates, this type of surgery is not used any longer. So here on the left is an example of the biatrial transplant heart. And then on the right, the bicaval, more commonly used operation now, the bicaval transplant. So where does transthoracic echo fit in heart transplant patients? Well, it can be used in the post-op period to identify surgical complications and early allograft dysfunction. And then, depending on the institution, it is often ordered every 6 to 12 months after heart transplantation. And it's also used after endomyocardial biopsy. One of the important things to note is that normal values derived from healthy subjects and published in the guidelines, such as the chamber quantification guidelines, do not apply to this population. And the reason for that is that thoracic surgery, the pericardiotomy, influence the contractility and the motion of the heart, and also result in altered ventricular interdependence. So this changes the way the heart works, and many of the normal values that are applicable to native hearts are not quite applicable to these heart transplant patients. And we'll talk about that in the coming slides. Also, the function of the donor heart may be affected by the cause of donor death. And we'll talk a little bit more about that as well, and procedures related to explantation, storage of the heart, and implantation in the recipient. So let's first talk about the left ventricle on transthoracic echo following heart transplantation. First thing, let's talk about the wall thickness. The wall thickness, as you can see in the right upper image there, can be increased in the first month due to inflammatory cell infiltration and edema. And this usually resolves after 3 months. Beyond 3 months, increased wall thickness in these heart transplant patients can be due to many factors, and we will go over that in the coming slides. Dimensions in these patients of the LV cavity are usually normal, and diastolic volume tends to be smaller. Ejection fraction tends to be more reduced than in the native heart patients. Strain also tends to be reduced in this population compared to native hearts. This is just a diagram showing you what happens to a longitudinal strain, for instance. The top portion refers to a normal heart, and the bottom portion refers to a transplanted heart. And you can see, for instance, that longitudinal deformation decreases in these patients. So why do we have increased wall thickness in heart transplant recipients? Well, one of the things that happens is that these patients can get persistent tachycardia due to the vagal denervation that occurs with transplant. And they also can have renal impairment that can impair wall thickness, systemic hypertension. The donor health in terms of, for instance, if the donor had intracranial hemorrhage and that was responsible for donor death, that can result in LVH in the donor heart and therefore in the recipient heart. Also, side effects of immunosuppressive treatments. Many are associated with hypertension and therefore with LVH. And remember that the types of immunosuppressive treatments that these patients are on includes steroids, cyclosporin, tacrol, azathioprine, and so forth. Also, if there's a donor-recipient heart size mismatch, LVH can be a compensatory mechanism in the recipient to maintain stroke volume. And repeated episodes of rejection can also result in increased wall thickness in heart transplant recipients. Any sudden increase in wall thickness warrants investigation and should raise the suspicion of acute graft rejection in these patients. What about the right ventricle on transthoracic echo? after heart transplantation? Well, we know that the right ventricle is very sensitive to pressure and volume overload. There's a close relationship between size of the right ventricle and function of the right ventricle, and it is affected by duration of hypothermic arrest, method of allograft preparation, ischemic time, and also mechanism of donor death. The size of the right ventricle is greater than the reference values on the chamber quantification guidelines. The function is reduced in the heart, in the transplanted heart. Chamber size often normalizes after heart transplantation, but the longitudinal function of the heart, of the right ventricle, partially recovers in about 2/3 of patients within 1 year. And here I have a set of normal values on the right, and these come from a recently published paper in JACE in 2018 in a population of heart transplant patients. You can see that they found TAPC was about 15 plus or minus 4, fractional area change about 40 plus or minus 8, free wall longitudinal strain of the RV minus 17 plus or minus 4, RV GLS also reduced compared to the normal population at minus 15 plus or minus 4. And 3D RV ejection fraction has also been shown to be reduced in these patients. This is an example of a heart transplant patient from our center. You can see that this patient is 3 months after heart transplantation. The right ventricle does look dilated. TAPC is 1.5 millimeters, fractional area change 34%, and the RV free wall strain minus 19%. What about the left atrium on transthoracic echo after heart transplantation? Well, larger left atrial dimensions are seen in heart transplant patients. Recipients of bicable transplants had smaller left atrial volumes than those who received biatrial transplants. This is an example here of a recipient of a biatrial transplant on the left and a bicable transplant on the right. And you can see just by looking at the atria that they are bigger in the biatrial transplant patient. What about diastolic dysfunction in the transplanted heart? Well, diastolic dysfunction can be difficult to diagnose. One of the reasons is that denervation of the donor heart leads to sinus tachycardia, which in turn leads to fusion of mitral ENA velocities. The biatrial technique often leads to two intact sinoatrial nodes beating at different rates, the donor and the remaining right atrial tissue from the recipient. And that can affect mitral inflow, causing beat-to-beat variability in ENA velocities. Atrial function can also be impaired because of the mid-atrial anastomosis between donor and recipient hearts. The bicable surgery technique may not affect atrial function as much as in the biatrial technique. So more on diastolic dysfunction in the transplanted heart. E over A can have a restrictive appearing filling pattern in patients with preserved ejection fraction. And this is a common finding seen in these heart transplant patients, mainly because the donor hearts are usually obtained from healthy young people, and these people have normal LV diastolic function. Later on in life, progressive myocardial fibrosis, for instance, in cardiac allograft vasculopathy, which we'll talk about in the coming slides, can lead to a restrictive filling pattern. Tissue Doppler E prime is influenced by translational motion of the heart. Early after transplantation, myocardial tissue velocities are low and recover gradually. They remain lower than the general population even after 1 year, according to some studies. Studies evaluating conventional diastolic function have failed to find any single parameter that correctly diagnoses diastolic dysfunction in these patients. This is an example of a patient 3 months post-heart transplantation. You can see the increased LVH, with increased LV wall thickness. You can see the ENA fusion. You can see both E prime, medial and lateral are reduced in this particular patient with an E prime medial of 4.6 and an E prime lateral of 5.3. Heart transplant rejection is the leading cause of mortality and graft loss in these patients. Unlike in kidney and liver transplantation, there are no biomarkers to detect heart transplant rejection. And there are two types of rejection. One is acute rejection, which is also called acute cellular rejection or ACR, and then chronic rejection, which often manifests as cardiac allograft vasculopathy. In acute rejection or ACR, usually this occurs within the first 6 months, but it can happen at any time. It is a T-cell mediated inflammatory response leading to myocardial edema and myocyte damage. Routine surveillance performed with endomyocardial biopsy, the histological interpretation of this is often subjective, and biopsy samples are taken from the interventricular septum. There's a 6% complication rate, including risk of right bundle branch block, tricuspid regurgitation, and RV perforation. So this is an example of a patient who was post-endomyocardial biopsy. If you can look at the top right-hand corner, you can see in the RV inflow view that there's a very eccentric jet of tricuspid regurgitation. If you look very closely at the view, the RV inflow view without color, you can see a small piece of the leaflet pointing towards the right atrium. And that is actually a flail leaflet. You can appreciate that eccentric TR jet again in the left bottom image. You can see in the apical 4-chamber view, focused on the right ventricle. You can see that eccentric TR jet in that image as well. If you look at the 3D images, on the top right, you are looking at the tricuspid valve from the right ventricular perspective on the left-hand side, and from the right atrial perspective on the right-hand side. On the bottom right, you're looking at the tricuspid valve from the right atrial perspective. If you look very carefully in the region of the septal leaflet, you can see that there is a flail of the septal leaflet. It's not very easy to pick up in this case because it was a small flail, and this patient actually has done well and has not needed any further intervention. So this is a schematic showing different non-invasive imaging techniques performed at various stages of cardiac involvement due to acute cellular rejection. You can see that echocardiography comes in pretty late at the bottom in detecting cardiac allograft rejection by change in diastolic or by presence of diastolic dysfunction or systolic dysfunction. And orange stars refer to those examinations that are clinically acceptable, and brown stars refer to those that are investigational. So you can see that most of our clinically accepted techniques are only able to pick up rejection late in the process. So we do need something to be able to pick up non-invasively rejection earlier in the process. Chronic rejection, or CAV, manifests as cardiac allograft vasculopathy. It can develop as early as 1 year after transplant. It's an immunological response against the vascular endothelium of the allograft. It's reported to occur in 20% after 3 years, 30% at 5 years, and up to 50% after 10 years. Existing methods for monitoring the cardiac allograft involve intracoronary angiography. So you can see that there is a need for a non-invasive approach to detect rejection early, also with chronic rejection. This is the schematic showing the different non-invasive imaging and invasive techniques that can be performed at various stages of cardiac involvement to detect cardiac allograft vasculopathy. And once again, echocardiography comes in very late in the process, helping to identify diastolic dysfunction or systolic dysfunction in these patients. So how do we detect rejection with LV ejection fraction? One of the problems with LV ejection fraction is that it's often preserved until late in the process. Decreased LV ejection fraction in the first year after transplant is a predictor for the development of acute rejection or CAV. It has low sensitivity for acute rejection, however, and there's no correlation between the magnitude of LV ejection fraction decline and rejection grade on biopsy. Reduction in LV ejection fraction late after cardiac transplantation correlates with CAV progression. Regional wall motion abnormalities are prognostic in these patients. What about diastolic dysfunction? Well, we know that diastolic changes occur before systolic abnormalities in acute rejection. Edema, immune-mediated expansion of the extracellular space, interstitial fibrosis, all impair ventricular relaxation. E over A, and isovolumetric relaxation time have limited ability to detect acute rejection as they are affected by other factors, such as higher resting heart rate, where the E and A merge, altered atrial morphology, preload, and donor age. Myocardial fibrosis, chronic graft rejection leads to restrictive LV filling and decreased annular velocities or E prime velocities. What about strain or deformation analysis? Well, we know that echocardiography is insensitive for detecting acute cellular rejection because the filling abnormalities that we have talked about so far are not seen in lower grades of rejection. Rejection is characterized by the cellular infiltrates and edema early on, which disrupts regional contractility. And left ventricular strain can look at regional, there is such a thing as regional deformation analysis. But the reports on use of LV strain in these patients in detection of allograft rejection are mixed at this time. So strain analysis cannot replace biopsy for rejection surveillance at this time. This is actually a prospective study that is suggesting that perhaps if we look at strain analysis in both the right ventricle and the left ventricle, perhaps that could be a stronger predictor of acute cellular rejection. And they found an RV free wall strain of less than 17% and a global longitudinal strain of less than 15.5% magnitude were independent predictors of acute cellular rejection. What about stress echocardiography? Well, exercise stress echocardiography has a low sensitivity for detecting CAV due to the inability of the denervated transplant heart to reach target heart rate with exercise. Dobutamine stress echo sensitivity has a sensitivity of about 70 to 80% for detecting significant CAV, and the sensitivity falls for mild lesions. The main contribution of stress echocardiography is to assess prognosis in post-transplant patients. A negative dobutamine stress echo implies less than 3% risk of MACE over 1 year. Other complications that you should know about post-transplantation is tricuspid regurgitation. Tricuspid regurgitation is actually the most common valve pathology after transplantation, and it is due to alteration in right atrial morphology in these patients that occurs after transplantation. It can be due to pulmonary hypertension that occurred in the recipient before transplantation. It can be due to RV enlargement and endomyocardial biopsy injury, as we saw earlier. Other less common complications include narrowing stenosis at the anastomosis sites, which can be SVC, IVC, aortic anastomosis, and the main PA. So in summary, the transplanted heart is unique. Guideline reference values do not apply in these patients, especially in the first year after transplant. Echocardiography is non-invasive, portable, easily accessible, and can be used to follow patients post-op and beyond. Serial echo showing no change from baseline have a high negative predictive value for acute cellular rejection. And this is one of the reasons why many centers do serial echoes in these patients. However, echocardiography has low sensitivity, less than equal to 50% for detection of acute rejection. And with that, I'd like to thank you for your attention.